Urethral carcinoma is an uncommon malignancy that originates in the urethra, the narrow tube responsible for carrying urine from the bladder to the outside of the body. Because the urethra is a small conduit, any abnormal growth inside it quickly interferes with urine flow and may be noticed early. The disease can arise anywhere along the urethral length, but its rarity less than 1% of genitourinary cancers makes it a diagnostic challenge. Understanding its basic definition sets the stage for exploring risk factors, biology, and management. The strongest contributors to urethral cancer are chronic irritants and infections. Persistent infection with high-risk HPV types introduces viral oncogenes E6 and E7 that inactivate P53 and RB, directly driving malignant transformation. Long-standing urethral strictures, often the result of repeated trauma, infection, or catheterization, produce ongoing inflammation and scar tissue that predispose to dysplasia. Chronic catheter use adds mechanical irritation and can promote bacterial colonization, further increasing mutagenic risk. These primary factors act like a rope that is repeatedly rubbed, eventually fraying and allowing weeds, cancer cells, to grow. Secondary contributors amplify the carcinogenic environment. Cigarette smoking delivers carcinogens, such as aromatic amines, directly to the urothelium via the bloodstream, increasing DNA mutations. Occupational exposure to aromatic amines and other chemicals, for example in dye, rubber, or petroleum industries, can similarly damage urethral epithelial DNA. Prior radiation therapy to the pelvis, whether for prostate, bladder, or colorectal cancer, leaves residual DNA damage in urethral cells, facilitating malignant change. These factors act like additional sparks that ignite an already smoldering inflammatory field. Rare familial syndromes underline the role of inherited DNA repair and tumor suppressor gene defects. Germline mutations in TP53, as seen in Lee-Fromeny syndrome, or in DNA repair genes such as BRCA1/2, can predispose urethral epithelial cells to accumulate mutations more rapidly. These inherited typos are passed from generation to generation and create a cellular environment where oncogenic hits are more likely to lead to cancer. Urethral carcinoma most often arises from the urothelium, also called transitional epithelium, or the stratified squamous epithelium that lines the distal urethra. Squamous cell carcinoma, abbreviated SCC, displays flat polygonal cells with intercellular bridges, reminiscent of skin. Transitional carcinoma, also known as urothelial carcinoma, shows cubital to columnar cells with an umbrella cell appearance that can stretch. Adenocarcinoma, though rarer, originates from glandular mucus-secreting cells. Histologic subtype influences prognosis and therapeutic choices because each lineage responds differently to radiation and chemotherapy. Common molecular events in urethral cancer mirror those in other urothelial malignancies. TP53 loss removes a critical checkpoint, permitting uncontrolled proliferation. CDKN2, a deletion disables the G1S checkpoint, further accelerating the cell cycle. Overactivation of the EGFR and ERBB pathway drives growth signals and can be targeted with tyrosine kinase inhibitors. Occasionally, FGFR3 activating mutations or PIK3CA alterations appear, especially in tumors with a papillary growth pattern. These aberrations act as broken electrical switches that keep the growth circuit permanently on. After malignant transformation, cancer cells infiltrate the lamina propria, then the muscularis, and eventually breach the periurethral fascia. Vascular invasion allows hematogenous spread, while perineural invasion provides a route to regional nerves and pelvic structures. Lymphatic channels transport cells to inguinal and pelvic nodes. In advanced stages, tumor cells may seed the lungs, liver, or bone. The process resembles a plant root digging deeper and extending shoots to new soil patches, establishing secondary colonies. Urethral carcinoma is extremely rare, representing less than 1% of all genitourinary malignancies. Reported incidence ranges from 1 to 4 cases per million persons per year worldwide. Because of its rarity, most data come from single institution registries or national cancer databases, limiting precise prevalence estimates. The low incidence translates into limited physician familiarity and delayed diagnosis in many cases. The disease predominates in males over the age of 60, reflecting cumulative exposure to risk factors such as smoking, chronic strictures, and HPV infection. Women can develop urethral carcinoma, often presenting with different anatomic patterns, more posterior urethral involvement. Geographic variations correlate with HPV prevalence and tobacco use. Regions with higher rates of HPV-related cervical disease, for example, sub-Saharan Africa, parts of Asia, tend to report slightly higher urethral cancer numbers. Overall incidence has remained low and relatively stable over the past decades. However, modest upward trends have been observed in countries with improved cancer registry coverage and rising HPV infection rates. Public health initiatives, such as HPV vaccination and anti-smoking campaigns, could flatten or reverse this trend in the coming years. Patients often notice hematuria, gross or microscopic, dysuria, painful urination, urinary frequency, urgency, and a sense of incomplete bladder emptying. Mechanical obstruction from a stricture or mass produces a weak stream and occasional spraying. Because these symptoms mimic benign conditions like prostatitis or urinary tract infection, clinicians must maintain a high index of suspicion when they persist despite standard therapy. When the tumor spreads beyond the urethra, constitutional symptoms emerge: unintended weight loss, fatigue, night sweats, and anemia. Enlargement of inguinal or pelvic lymph nodes may be palpable. Advanced disease may produce bone pain or respiratory symptoms if distant metastases develop. These systemic signals indicate a more aggressive disease stage and guide staging workup. On inspection, a visible ulceration or indurated nodule may be seen at the meatus. Palpation can reveal a hard fixed mass within the penile shaft, anterior urethra, or perineal region, posterior urethra. A stricture may be evident as a narrowed segment with a firm feel. These findings are analogous to feeling a knot in a rope, a localized firm irregularity that does not move freely. A thorough history focuses on urinary symptoms, prior catheterizations, sexually transmitted infections, especially HPV, smoking, occupational exposures, and previous pelvic radiotherapy. Family history of early onset cancers raises suspicion for hereditary syndromes. Physical examination follows the symptom review, looking for periurethral masses, lymphadenopathy, and signs of chronic inflammation. This information helps differentiate benign urethral disease from malignancy and prioritizes further testing. Urethroscopy allows direct visualization of the mucosal surface, identification of suspicious lesions, and targeted biopsy. The endoscope, typically 2 to 4 millimeters in diameter, can navigate the entire urethra. Findings may include irregular papillary growths, ulcerated areas, or strictures with overlying neoplastic tissue. Photographic documentation assists in mapping the lesion for staging and surgical planning. Cross-sectional imaging defines the depth of invasion and regional spread. MRI provides superior soft tissue contrast, delineating tumor extension into the corpus spongiosum, corpora cavernosa, and surrounding fascia. CT evaluates pelvic lymph nodes and distant metastases. High-frequency ultrasound is useful for superficial anterior lesions. 18-FFDG PET-CT can detect metabolically active nodal disease and occult distant sites, guiding therapeutic decisions. Biopsy specimens are fixed, embedded, and stained with hematoxylin eosin for routine morphology. Immunohistochemistry IHC markers help determine lineage. P63 and CK5/6 favor squamous differentiation. GATA3, uroplakin3, and CK7 suggest urothelial origin. And CDX2 or CEA may indicate adenocarcinoma. P16 overexpression is a surrogate for HPV-driven tumors. The combination of morphology and IHC yields a definitive diagnosis and informs targeted therapy options. The JCCT-NM classification assigns T depth of primary tumor invasion, for example T1 confined to urethral mucosa, T2 invading corpus spongiosum, T3 extending beyond the urethral wall. N regional nodal involvement, N0 none, N1 single ipsilateral node, N2 multiple nodes. M distant metastasis, M0 none, M1 present. Stage grouping combines T, N, and M to predict prognosis and guide treatment. Accurate staging requires integration of endoscopic findings, imaging, and pathology. 3 principal histologic types exist. Squamous cell carcinoma, most common in men, linked to HPV and chronic irritation. Transitional carcinoma, also called urothelial, often posterior, resembling bladder cancer. Adenocarcinoma, rare, arises from periurethral glands. Each subtype exhibits distinct molecular signatures, response to therapy, and survival outcomes, making histologic classification essential for personalized care. Anterior urethral tumors arise in the penile segment, bulbar and pendulous, and generally require penile-preserving surgery. Posterior urethral cancers involve the membranous and prostatic portions, often necessitating more extensive pelvic surgery, cystourethrectomy. Location dictates the surgical approach, potential for urinary reconstruction, and functional outcomes such as continence and sexual function. Grading assesses how much tumor cells deviate from normal epithelium. Low-grade lesions retain orderly architecture, display minimal atypia, and tend to grow slowly. High-grade cancers show marked pleomorphism, high mitotic activity, and a propensity for rapid invasion and metastasis. Grading, together with stage, is the most powerful predictor of survival. Surgical management ranges from local excision for small, low-grade anterior lesions to radical cystourethrectomy with pelvic lymphadenectomy for extensive posterior disease. Organ-preserving techniques, such as segmental urethrectomy with primary anastomosis or laser ablation, aim to maintain voiding function. Reconstructive options include perineal ureterostomy, flap-based neourethra, or continent urinary diversion, depending on the extent of resection. External beam radiation therapy, EBRT, delivers high-energy photons or protons to the tumor while sparing adjacent tissue. Brachytherapy places radioactive seeds or catheters directly within or adjacent to the urethral wall, achieving high-dose localization. Radiation can be curative for early-stage disease or used as adjuvant therapy after surgery, particularly when margins are positive. Toxicities include urethritis, strictures, and rarely erectile dysfunction. Systemic chemotherapy is reserved for locally advanced or metastatic disease. Platinum-based doublet cisplatin plus 5-FU or gemcitabine are standard, mirroring bladder cancer protocols. Taxanes docetaxel or paclitaxel provide activity in refractory cases. Dose intensity and renal function must be balanced, as many patients are older with comorbidities. Chemotherapy can be given neoadjuvantly to downstage a tumor before surgery or concomitantly, with radiation, chemoradiation. Molecular profiling identifies actionable alterations. EGFR inhibitors erlotinib and gefitinib for EGFR-amplified tumors. FGFR inhibitors erdafitinib for FGFR3 mutated disease. HER2-directed therapies trastuzumab in HER2 positive cases. Immune checkpoint blockade with pembrolizumab or nivolumab is approved for PD-L1 positive or microsatellite unstable urethral cancers, offering durable responses in a subset of patients. Clinical trials are exploring combination regimens to overcome resistance. Evidence supports combining modalities to improve local control and survival. Typical regimens include surgery followed by adjuvant radiation or concurrent chemoradiation as definitive therapy for organ-preserving intent. Multimodal treatment targets the tumor from multiple angles. Surgical excision removes bulk disease, radiation sterilizes microscopic residuals, and systemic therapy eradicates distant micrometastases, much like a three-pronged siege on a fortified castle. Post-treatment surveillance involves cystourethropy, urine cytology, and cross-sectional imaging, MRI or CT, every 3 to 6 months for the first 2 years, then annually up to 5 years. Physical examination focuses on inguinal nodes and urethral patency. Early detection of recurrence permits salvage surgery or localized therapy, which improves overall survival. Patients are also counseled on lifestyle modifications, smoking cessation, HPV vaccination to reduce secondary malignancies. Prophylactic HPV vaccination, non-avalent vaccine covering 9 high-risk types, administered before sexual debut, dramatically lowers the incidence of HPV-related urethral SCC. Smoking cessation eliminates a major carcinogen source. Public health campaigns targeting these modifiable risks constitute the cornerstone of primary prevention. High-risk individuals, men with chronic urethral strictures, long-term catheter users, or a history of penile HPV lesions, should undergo periodic urethropy, for example annually, to detect dysplastic changes before invasive cancer develops. This surveillance is analogous to routine pipe inspections for heavily used water lines, enabling early intervention. Prompt treatment of urethral strictures, endoscopic dilation or urethroplasty prevents chronic inflammation. Minimizing catheter duration, employing sterile techniques, and using intermittent rather than indwelling catheters reduce trauma. Treating chronic urinary tract infections and ensuring good genital hygiene decrease the inflammatory milieu that fuels carcinogenesis. 5-year overall survival approximates 60% for stage 1 disease, confined to urethral mucosa, but falls below 20% for stage 3 to 4 disease with nodal or distant metastasis. Squamous histology generally carries a slightly better prognosis than adenocarcinoma when matched for stage, while poorly differentiated tumors have the worst outcomes. Early detection is therefore pivotal for improving survival. Key adverse prognostic indicators include large tumor size, greater than 2 centimeters, deep stromal invasion, T2 to T3, positive lymph node status, N+, high histologic grade, and presence of vascular or perineural invasion. Molecular markers such as TP53 mutation or high Ki67 proliferative index also correlate with aggressive behavior. These factors are incorporated into risk-stratified treatment algorithms. Multimodal therapy, surgery plus adjuvant radiation or chemoradiation, yields the highest disease-free survival, especially in locally advanced disease. Single modality treatment, either surgery alone or radiation alone, shows inferior local control and higher recurrence rates. Tailoring therapy to tumor stage, histology, and patient comorbidities maximizes benefit while limiting toxicity. Comprehensive next-generation sequencing panels now routinely assess urethral tumors for actionable mutations FGFR3, PIK3CA, ERBB2. Biomarkers such as PDL1 expression, tumor mutational burden, and HPV-16 status guide immunotherapy eligibility. Molecular profiling functions as a GPS, directing clinicians toward personalized regimens rather than one-size-fits-all chemotherapy. Phase 2 trials are evaluating EGFR inhibitors erlotinib and HER2 directed agents trastuzumab emtansine in molecularly selected urethral cancers. Immune checkpoint inhibitors, particularly pembrolizumab, for PD-L1 positive or MSI high tumors, have shown durable responses in a subset of heavily pre-treated patients. Early data suggest combinatorial approaches, for example PD-1 blockade plus anti-VEGF therapy, may overcome primary resistance. Robotic-assisted laparoscopic urethrectomy allows precise dissection with minimal blood loss, preserving neurovascular bundles when possible. Transurethral laser ablation and endoscopic excision offer organ-preserving options for small, superficial tumors, reducing postoperative morbidity and preserving sexual and urinary function. These technologies are comparable to using a precision scalpel rather than a large saw. Current trials, for example NCT0 456789, compare definitive chemoradiation versus radical surgery for locally advanced urethral carcinoma, aiming to define the optimal balance between oncologic control and quality of life. Other studies, NCT0 521345 and NCT0 601122, assess pembrolizumab monotherapy and FGFR inhibitor combination regimens in metastatic disease. The outcomes of these trials will refine standard of care algorithms and may expand indications for immunotherapy. Hybrid PET MRI provides simultaneous metabolic and high-resolution anatomic data, improving detection of subcentimeter nodal metastasis. Optical coherence tomography, OCT, catheters enable real-time microscopic imaging of the urethral mucosa during endoscopy, facilitating targeted biopsies. These advances act like a high-resolution map, allowing clinicians to chart tumor borders with unprecedented precision before surgery or radiation planning.